the last speaker of this session, but not least. And our last speaker actually is Assistant Professor Dr. Adel Elboghdady, and he is going to address us on the number of embryos to transfer during the IVF ISHRI Guideline 2023.
بسم الله الرحمن الرحيم والصلاة والسلام على أشرف الخلق أجمعين سيدنا محمد. It's a great honor to me to present here tonight among the famous and the expertise in the field of ART all over the world. I promise all of you that I will finish before my time allowed for me. So, my topic today about elective single embryo transfer. We can define selective embryo transfer. It is a procedures in whom a woman can be transferred single embryo in spite of multiple embryos are available. So actually, the primary goal of selective or elective single embryo transfer is to decrease the multiple pregnancy rate associated with IVF. General information in the United States, approximately around 30% of pregnancies achieved by IVF are twin. This incidence in triplet and high order pregnancy around 3% to 4%. So transferring more than one embryo increase the chance of multiple pregnancy. So why many communities and society allow single embryo transfer? According to the reproductive facts, the ASRM, this is decrease the risk of pregnancy complication, either medical disorder with pregnancy or the complication related to the pregnancy, or the fetal and neonatal complication. Decrease the costs, either direct cost related to the ART treatment itself, or the pregnancy or the neonatal direct costs, or indirect costs related to the decrease the reproductivity. Reduce the psychological burden. We have several studies demonstrated that pregnancy achieved by IVF, these women suffer from stress and depression more than women that can achieve pregnancy spontaneous. So, the ISHRI guideline demonstrated that elective single embryo transfer can be helpful or useful for the mother to achieve safe pregnancy and allow for vaginal delivery, for the society to increase the healthier children and the healthier families, for the baby to allow for full-term baby and healthier childhood, and for the family to the interaction with the family. So, the current evidence, this evidence or this publication, a review of the maternal and perinatal outcome associated with twin pregnancy versus single-tone pregnancy achieved by IVF, demonstrated that for maternal risk, there is increase in the fold of cesarean section up to 4-fold, and increase 2-fold in the odds of pregnancy-induced hypertension, 3-fold increase in the preterm labor, and around 2-fold increase in the odds of preeclamptic toxemia. So, for the fetal risk, increase the risk of preterm also for the preterm labor, increase the odds of low birth weight baby, and increase the admission in the neonatal ICU, and finally increase the odds of stillbirth. And this is the study published in the ASRM. So, actually, ideally, the goal of ERT is to achieve healthy single-tone gestation. According to the SART, Society of Assisted Reproductive Technique, in 2017, around 12% of women less than 38 years of age have twin pregnancy after successful IVF. This percentage drawn to 23% in 2014, but still significantly more than baseline. Many hot topics mentioned today and tonight and yesterday around the pre-implantation genetic PGTA, all of them recommended that screening test for all patients undergoing IVF by PGTA has not been demonstrated, but some centers in Europe and USA reported higher birth rate after PGTA with elective single embryo transfer in favorable prognostic patient. The PGTA to lowering the risk of clinical miscarriage is also unclear. So at present, the use of PGTA with aneuploidy cannot be recommended. When achieving pregnancy with high order pregnancy, we can offer for the patient to fetal reduction, but these procedures may result in many complications such as loss of all fetuses, infection, etc. So it doesn't completely eliminate the risk associated with multiple pregnancy, and it have adverse psychological consensus. This study published in the Fertility Sterility showing that elective single embryo transfer in women less than 38 years can reduce multiple pregnancy rate with no affection on the live birth rate. Another study, single eubloid blastocyst transfer in women more than 42 years, showing that good blastocyst, good pregnancy rate similar to those transferring to untested blastocyst, with dramatically reducing the risk of miscarriage, the risk of twin pregnancy. So PGTA for aneuploidy may be a tool to reduce the rate of multiple gestation, especially in women more than 37 years. But it can be offered in many centers with the physician and the patient may consider proceeding with an additional embryo to be transferred, and it has a debatable condition because the live birth rate after several unsuccessful cycle can be decreased from first cycle of unsuccessful pregnancy from 30% up to 16% in the fifth unsuccessful IVF. So we can ask some question. Who are good candidates for elective single embryo transfer? Women less than 35 years undergoing their first ART, have successful pregnancy in previous ART cycle, have a relatively large number of high quality embryo, and have a good number of embryo for cryopreservation. Who are favorable for prognosis of elective single embryo transfer? Transfer of eubloid embryo should be limited to one, regardless the patient age. Patient less than 35 years should be strongly encouraged to receive elective single embryo transfer. Between 35 to 37 years of age, strong consideration should be made for elective single embryo transfer. Between 38 to 4 years, no more than 3 untested cleavage stage or 2 blastocysts should be transferred. Between 41 to 42 years, no more than 4 untested cleavage stage or 3 blastocysts. And this is published in the SRM and SART in 2021. So, how is the best embryo to be chosen? Laboratory grading each embryo based on its appearance, including looking at number, size, rate of development, and other factors. Different grading systems are used and may vary from clinic to another clinic. All of them depending on whether the embryo is being evaluated in cleavage or blastocyst stage, and none of them can be excluded or can be concluded that which good embryo can achieve the life offspring. This is a recent study published in the Nature Communication showing the effect of single blastocyst stage versus single cleavage stage in the cumulative live birth rate with good prognostic patient, showing that no difference between blastocyst transfer or cleavage stage according to the primary outcome in the cumulative live birth single tone but has a significant, highly significant difference in the secondary outcome between blastocyst and the cleavage according to the cumulative biochemical pregnancy. When to offer to transfer more than 2 embryos, we have different criteria. Advanced maternal age more than 35 years or 40 years, such as in USA. After multiple failed IVF cycle and it has a debatable question, such as in India, and in poor quality embryo. BGT when embryos undergoing genetic testing more than one can be transferred if viable. Frozen embryo transfer in some countries allow transfer more than one due to the potential lower viability on patient request with informed consent. What about Arab countries? In the United Arab Emirates allow 1 to 2 embryos can be transferred, maximum 3. In Kuwait, 2 to 3 embryos. In Oman, 2 to 3 embryos. In Saudi Arabia, typically allow 2 to 3 embryos. In Iraq, information limited but allow 2 to 3 embryos. Syria, unclear but practice allow 2 to 3 embryos. Algeria, follow the international guideline 1 to 3 embryos, and Morocco 1 to 3 embryos. What? So actually, expectation 2 embryo transfer guideline, the Egyptian guideline allow transferring more 2 embryos in patient over 40 years. Some recommendations such ASRM suggested expectation in patient over 35 years. So, Mr. Chairman, my talk home message, this is the guideline by the ISHRI in 2023. Number of embryos can be transferred during IVF exit cycle. The decision to perform double embryo transfer instead of single embryo transfer should not be based on the number of previous unsuccessful ART cycle, and the decision should not be based on the duration of infertility, and the decision should not be based on the female age. Women aged less than 38 years should receive elective single embryo transfer. The decision to perform double instead of single embryo should not be based on the pregnancies or live births from ART cycle. The decision to perform double instead of single embryo transfer in fresh or frozen embryo transfer cycle should not be based on the endometrial characteristic. In fresh cleavage stage and in blastocyst embryo transfer decision not based on the embryo criteria. Cryopreserved warmed cleavage stage or blastocyst embryo transfer, the decision should not be based in the embryo criteria. And finally, BGTA outcome should not be considered when deciding to perform double instead of single embryo transfer. Thank you so much.